Good day, everyone. Welcome to another episode of Ultrasound Podcast, where we bring together the best minds of ultrasound from around the globe. I am truly thrilled to introduce a very special guest. She is none other than Dr. Renee Dversdal. Renee is a dedicated internist and a phenomenal name in the field of point of care ultrasound. Renee is the professor of medicine at the Oregon Health and Science University. She is the medical director of simulation and formerly the director of point of care ultrasound. Her passion for utilizing point of care ultrasound transformed patient care, allowing for faster and more accurate diagnosis at the bedside. With her vast experience in internal medicine and a very special focus on innovative technologies, she is making a significant contribution to modern healthcare. Without further delay, please join me in welcoming the ever amazing Dr. Renee Dversdal. Thanks, Renee, for joining us. All right, Renee, thanks for joining us. In Australia, we have started point of care ultrasound for a few years, and it's really interesting to know what is happening on the other side of the pond in the North America. So, Renee, tell us a little bit more about your POCUS journey. You have been in this field for quite a while. How this has evolved over the last few years?
Well, thank you for having me. I wish I were with you in your beautiful background, but instead I'm in Oregon, and this is preferable to the clouds, my A and B lines. So yeah, it's just I love talking POCUS with anyone, anytime, anywhere. So I appreciated the invite. So for me, my POCUS journey, I'm internal medicine trained, and I did my residency back in Boston at Massachusetts General Hospital. And so I was always doing procedures with ultrasound. That was never a question. I like to joke that procedures are the gateway drug to POCUS. So the procedures were with POCUS, and then we have to do emergency medicine rotations as a part of your internal medicine residency. And I specifically remember being in the emergency department my third year of residency, and there was a case came in, and I was being a classic internist with a differential diagnosis this long. And I said, I won't really know until I get my labs and my EKG and my ultrasound and my blah, blah, blah. And then the attending had come out and said, oh yeah, it's right, lower lobe pneumonia. And I was like, what is that witchcraft? And why can't I do it? Why don't I know that? So that was kind of the first tease. And then a coworker or a co-resident of mine had on an overnight admission, or I think he was supervising the intern for a late evening admission. And the story just didn't add up. It was a chest pain rule out MI. And so the jugular venous pressure was very high. And so he ended up ultrasounding and finding a pericardial effusion that entirely changed everything overnight. So those two things were right at the end of my residency. And I just thought, that's something I have to learn, I have to know, I have to do. And so that sort of planted the seed. And I was then out of residency, followed around a lot of ER doctors, went to as many POCUS courses as I could find, and was very fortunate at Oregon Health and Science University to have a provost who's very supportive of simulation and ultrasound, and helped me and our cohort to help build a program while I was learning, and it just kind of flew from there.
Excellent, excellent. What an amazing journey. So during this journey, what are the different clinical applications you have found where POCUS made a huge change in the clinical assessment and management?
Yeah, so I have two favorites. Everybody, cardiac ultrasound and Vexus and all that. It's like cool, it's sexy, it's new, not cardiac, but I love bread and butter basics. Just the most helpful things in the world to me are the lungs and the bladder. People always hear me wax poetic about how darn helpful bladder ultrasound is. I have had cases, so patient admitted with heart failure, severe end stage heart failure, and he's not diuresing. We're not getting urine output despite hammering with very large doses of diuretics. And had a Foley put in, Foley removed because the bladder scanner kept saying that it was positive for several hundred cc's. The patient was already distrustful of the medical system, and we traumatized him and his urethra for this positive bladder scan. And ultimately, he ended up, we did a reel the next day. The team, we did full bladder ultrasound, and he actually had ascites. He had cardiac ascites from right heart failure that had never been diagnosed or noted before. And the bladder scanner was picking up that ascites as urine. So we just hadn't diuresed him enough. We hammered even further. He starts peeing and everything goes great. There's also cases where the Foley catheter is clogged or pulled and it's in the prostate. I just could talk for an hour about how useful bladder ultrasound is. And then as you can see from this, to me, just wet versus dry or normal, abnormal, I forget, I'm reversed on the screen, abnormal versus a normal A-line pattern. The lungs are, I listen to every patient, but we just know ultrasound is better than our physical examination. It's better than 2-view chest x-rays at everything from pulmonary edema to pneumothorax to pleural effusion to pneumonia. Like it just performs so well. So I love all of ultrasound, but those are my two. If I were stuck on a desert island with only 2 organs I could ultrasound, it would be the bladder and the lungs.
Excellent, excellent. Yeah, I can remember once one of the nurses put a catheter in a female patient, and she was very worried though that nothing is coming out through the catheter. And when I did the ultrasound, she was like your patient, has big ascites, and the catheter was not even in the bladder; it was in the vagina. And
oh yeah,
I don't know
it's
how
so easy to confirm. So easy.
Yeah, amazing. Thanks.
Yeah.
And during your use of application of point of care ultrasound, Renee, I'm pretty sure, like many of us, you came across different challenges. Tell us a little bit more about the different challenges that you faced and how you have addressed them, or what are the challenges you envision in the future to come and how we can address them.
Yeah, wonderful question. So I think the challenges have changed a little bit recently because when I was starting out learning this, so I've been out of residency for over 12 years now, which, you blink and a decade goes by. So in the beginning, I didn't know what I was doing and I had to try to build the skills, but I also couldn't find a machine to do it. There was one machine for all of the hospital wards. And so you would have to go to the ED or the ICU, et cetera. So machine access was very, very large component. Nowadays, there's more companies, there's more handhelds, there's more competitive pressure. So accessibility, I feel, is no longer a true challenge. Most people can buy a device with their CME budget. So that was one that I think has changed. Confidence. So education is one thing, learning, practicing, having someone to help you, give you formative feedback and review, all very important. But also the confidence to make a clinical decision once you've learned, because we're all terrified of doing the wrong thing. But I like to tell my learners, especially the residents when they're up in the internal medicine and even continuing professional development, ultrasound is not a diagnosis. It's another piece of data. So these B lines, these are like visual crackles. But I have to be the doctor or the clinician and say, what's the JVP? Do they have a fever? Are their legs swollen, etc. So ultrasound is giving me a visual sign cue diagnosis like interstitial syndrome, but I then have to clinically correlate it. So that correlation piece is the part that takes the most practice, and sometimes we don't have confidence in ourselves. And I just tell people, if you find something that just doesn't seem to fit and you're like, that doesn't make any sense, phone a friend, get a confirmatory study, go ask someone else. So that's another thing. The education we're trying to push out more broadly. And then when we're teaching in medical schools and such, trained faculty is always a challenge. And slowly we're getting the students coming through and more people are becoming faculty, but that we remain to have this kind of large generation of current and current practicing, and we're trying to get grassroots up and top down and get penetration.
Mhm. Excellent. Yeah, it's amazing to see. There are so many challenges over the last few years, but we are getting there. We are addressing those challenges.
Sure.
And as we address the old challenge, some new challenges appear. And at the end of the day, this is helping everybody. This is helping the patients at the end of the day. Now that brings
Yeah.
up the next topic, Renee, that is the training. And I know that you have got a lot of involvement with the medical education and training. You've got quite a few publications on this topic itself. So tell us a little bit more about this training, especially starts from the medical school and then the clerks and then the undergraduate trainees and also the fellowship training. I believe you are involved with all of them. Tell us a little bit more about it.
Yeah, so more recently in my university role, I've taken over as the medical director of simulation at my university. So there's a new medical director of POCUS. So I'm a little bit less hands-on than I used to be, but they're doing amazing. And it was time for me to get out of their way and let them run it. But I still help out. So I think just like any curriculum ever, we don't just say, I want to teach something.
Mhm.
We have goals and objectives. We have the outputs in mind about what we're trying to create. So you need to look ahead, what's out there in the community, and what do you want your learners to get to? And then you can build it back from there. So for instance, the preclinical medical students, they haven't even taken their step 1 boards. They're very mired in our foundational sciences.
Mhm.
And I think that ultrasound is an incredible tool to teach ultrasonographic anatomy, physiology, image acquisition. We can have them Valsalva and their eyes light up as the IJ pops out. So we can teach what they already need to learn while they're learning a hands-on visuospatial skill. It's like we're teaching them a clinical skill that they don't even know that they have to care about yet. And so, but for them, clinical correlation is not my goal. I'm not trying to teach them how to take a differential diagnosis of this into a diagnosis in my patient. I'm trying to teach them ultrasound acquisition and ultrasound some interpretation. So that would be for our preclinical students. I like to say, out of Ohio State, Bonner et al., there's the I-AIM paper. So this is their structure for what you have to learn or know to be good at POCUS or competent. So your indication, your acquisition, your interpretation, and your management. I like to say there's 3 POCUS pillars because they kind of break down into Bloom's domains. So your technical or physical is your image acquisition. I have to put on my sonographer hat and acquire that image. And then your cognitive aspect of Bloom's domains is that image interpretation, pattern recognition, seeing things. And then that sort of behavioral, that is what I think of as my clinical correlation. So when we move up into the clinical clerkships, maybe I'm starting to give them some clinical correlations, differential diagnosis. But when I get to my faculty and my clerks or residents, as we would say here, they need to know how to clinically interpret that. We're teaching them to be true internal medicine or family medicine or whatever, emergency medicine doctors. So it just depends on the level that you're trying to train them to. And one pitch I will say for training, because there's a phenomenal group there in Melbourne, and notice, because I studied abroad in Perth, I didn't say Melbourne. I didn't say it the American way. So
Right.
in Melbourne, you have ZEDU ultrasound training
Yes.
solutions. So ZEDU, and I've learned a ton from them at the national, international courses.
Mhm.
So my pitch is don't forget your sonographers. Your sonographers, it's a different skill set than acquiring images, but an educational sonographer can revolutionize how you see things, how you teach things, how you do things. And so we at Oregon or OHSU, probably pre-pandemic by several years, we did a train the ultrasound trainer course with them. and Christine Schutzer on my team, Kevin Pyro, et cetera. So we were able to talk about how do you break down those skills into how you're going to teach them moving forward. So clearly I could talk about training forever, but don't forget your sonographers, especially if you are resource limited and you don't have the physicians that know what they're doing. Are you next to an ultrasound school? Could you leverage them? So anyway, going off to troubleshooting.
Yeah. Thanks for sharing that. So one of the aspect obviously is training of the senior doctors who are already specialists in their field, but probably they have not that expertise in point of care ultrasound. And you have got one interesting paper teaching the old dogs new tricks. So how to treat the senior faculty. Tell us a little bit more about this, Renee.
Yeah, so this came about, so the first author, Dan Restrepo, and actually, so second author, Thomas Hain, they're both physicians back, internal medicine at Mass General. And again, I had done my residency there. And so POCUS, I mean, this was published in 2023. We did the teaching in 2019. So I even started talking to them before that, 2017, 2018. So it still was a little bit out there for a very traditional program. And so the program director had reached out and said, hey, you're an alumnus, you're nationally known for this. We're interested. Could you, talk to our team? We could talk about doing a training or something. So we ended up setting it up. And the third author here, Christine Schutzer, again, she's our incredible educational sonographer. Well, that's what she started at OHSU. And now she's the operations and curriculum director for the entire university POCUS group, which is very cool. So anyway, they said, we want to do this train the trainers or POCUS education for senior faculty. And the faculty were to a place where they were receptive to it because all the kids are doing it. The students are coming in, the residents are starting to do it, and the faculty start to realize they're doing things that I don't understand. And I need to try to get a handle on this so that they're the master diagnosticians, right? They're the master clinicians. So they might be the best at that clinical correlation piece. But if they don't know anything about test characteristics, false positives, false negatives, etc., they are not able to guide their team as a teaching doctor. So they were ready for it. And so we were able to fly out there and do this course. And Gigi Lou's another internal medicine hospitalist. So she came up from Hopkins. So I'm going to tell you one of my secrets, which is that you can motivate with the carrot or the stick. And in this case, knowing that Mass General is a very traditional institution, Gigi's a phenomenal teacher anyway. Anyone that can ever learn from Gigi, do it. She's amazing. But also it was a dual-edged sword because she's running the Hopkins curriculum and able to tell them what all they do for the Hopkins residents. And that's the stick to say, you guys better keep up. You're going to fall behind if you don't do this. So that was kind of the lead into this piece. But none of us I'd done faculty development courses before, but not for people that I knew and people that I respected and people that I knew were like national and international leaders on these things. So we started kind of running it like normal, and then everything would go an hour over because they have all these crazy intelligent questions and they're not okay just saying, but why does the IVC do that? Because it's slightly different than the IJ and the CV wave. And so they went all the way into the weeds. And then we realized as well, not everyone is comfortable translating their mental anatomy into physical movements. And so kids these days, on the computers and the interwebs, they're very facile with video games and a lot of other things. And so we also realized, okay, so we need to have a lot of time in our didactics for questions. And I'm probably giving away, I forgot some of the points, but we learned a lot. And we just thought, number one, maybe this will motivate other people. So I tried to shame MGH with Hopkins, saying, look at what they're doing, and it helped push. And then, we can publish this and try to push other places too. Like, look at what they're doing. What, you all need to be invested as well. And then, of course, Dan Restrepo is just an incredible clinician and educator. And we thought, hey, it's, also time to let's get you as some first author. Like, he pitched the idea and we were like, heck yeah, let's do this.
Yeah, so one of the technique you have mentioned about, first of all, developing a hook. Tell us a little bit more about it. How can you hook somebody, especially the senior doctors, in this
Yeah.
sound?
So I guess I should have, instead of carrot and stick, I should have said like a hook or a fishnet coming behind them.
Yes.
So the hook was that they do, even these incredible mid to, senior career people, they love learning. They love learning and wanted to learn something new and different, a different tool set to put in their kit. And the other one is, again, the residents are coming along and we want to feel competent as we are guiding our residents. And so that was, I think, kind of the combination of the hook and the net. And then the net also being safety, psychological safety, because these people, I mean, they're all so wonderful, but they're not used to not knowing things, right? Like, that's not their everyday life. So we had to make it very psychologically safe. Like, we're all learning something new and different, and there are no dumb questions. And someone might get it faster than you, and that's okay. But you might get this other thing faster than them. So there's no comparisons. We're all starting from zero and making it psychologically safe. So that's kind of the other part of the net and getting their investment. But they were there and incredibly excited to learn. And one of them afterwards said it was the most fun course he'd ever taken, like ever. And he's like, he was like on fire. He's like, I've learned something new and amazing. And it was really cool to see how they embraced it.
Excellent. Yeah, thank you. And also you have mentioned about the use of the callback techniques.
Yeah. So again, trying to take what they already know and know so well, and then translating that into the ultrasound. So, they have percussed agophony a million times. So let's say anechoic fluid or pleural effusion, like now you're visualizing that agophony, like that hollowness when you're tapping, and now picture that air on top. That's why. And so trying to tie those two things together, we really like to do a little bit of didactic, some hands-on, and then come back to case review afterwards with more abnormals. You can work again on that clinical correlation piece, but also the spaced repetition. It's not just like all image interpretation. Then you're done with it. You're an expert. And yeah, so I think those are really the main things, is trying to figure out what, if you have time, you can even go into how they learn and other things, but this was 2 days and we just had to go to it. So yeah.
Excellent. Thank you for that. As you have mentioned earlier, that the seniors, they have got that knowledge, but they want to try to correlate their knowledge with this ultrasound finding, and they come up with these whys.
Yeah, and that was tough for us. Because some of the things I just was like, I don't know, you guys, it just is, okay? It just is. So trying to dig I think in hindsight, a little preparation. I mean, I've seen some really awesome videos and discussions about our beelines from mini reverberations, or is it like the tetrahedron model, etc. I don't know. They were all the way at that level of detail. So I think, and it wasn't just what is the data here, what study showed it's better than a chest X-ray. It was really that why, and also you have to be confident in yourself as a teacher to say, I don't know, and it doesn't actually matter. So the false positives, false negatives, etc. Super important. But some of the things, like, I promise this will never actually make your diagnosis. So you got to be comfortable just saying, and we're going to move along, and maybe phone a friend too. Yeah.
I find this all the time, especially with senior faculty members, that they come up with these different questions, and sometimes I feel that I need to know more about it. It
Yeah.
can be quite a challenging situation. You have
Mhm.
mentioned about the leveraging of existing knowledge like
Yeah.
JBP and the third heart sound with the ultrasound finding.
Yeah. So anything here that you can correlate to what they're already so good at.
Mhm.
So I love all of my levels of learners, doesn't matter if it's a nursing student or end career, parasternal long axis and hitting pause and sitting forward and backward to the mitral valve and the aortic valve and S1, S2, S1, S3, or sorry, S3. We were talking about an S3 here. But for my students, my preclinical students, and even clinical students and residents, we're trying to take that ultrasound to solidify those things. And then in the reverse of this, they're so good at that S1, S2, that you're able to say, that's a visual S1, that's a visual S2. And you know this because of X, Y, and Z. It's like that reverse process, kind of back translating it for them.
Absolutely phenomenal. And of course, the ultrasound is not complete unless lots of hands-on practice is done, and that
Yes.
influences the whole training process.
And in that paper, they talk about, Dan and Thomas, there's this DRIP curriculum that I believe Dr. Hain, Tommy's working on publishing. So that DRIP later, you cannot just do the bolus. If you only do the bolus, we all know skill decay happens. So you must do the DRIP ongoing. And I just tell them, like, you can't hurt a patient with an ultrasound probe, right? So I sort of have this verbal consent. I'm learning ultrasound. I'm not a radiologist or a sonographer. If I see anything weird, I'll tell your team or we'll order a confirmatory study. So we really emphasized in person right then, hands-on practice, as many reps as possible. And then also that they have to keep getting reps afterwards. And one thing we found over time, taking a lot of time up front to set the stage on your probe movements, what happens when, and avoid the fishing where they do this all at once. This is any learner, but if you do this, you have no idea how you got there and why. So really making it very concrete. Try, let's rock. Nope. Slide. Oh no, now we're over the lung. Okay, so it was a rock that way, and trying to make sure they're just doing one movement at a time. Definitely helps them solidify their skills faster.
Thank you. In case of the clerkship or interns or residents training, is there anything that you would like to advocate in terms of the training and supervision from the faculty?
Yeah, so this paper we decided to publish because we were all pretty tired of hearing everyone say, like, if you go to a big ultrasound conference, they're like, well, the internists just aren't doing, some radiology places have electives. Almost every emergency medicine place has electives, department for students. And we're like, us internists are doing stuff too. And so we thought it would be nice to show a large variety of what we're doing. University of South Carolina, they started way back in the beginning. And I can't remember, there's a table in there where we say which schools have WIT, but they have, I want to say, an OSCE and mandatory image submission and other things. Whereas at OHSU back in the day, it was just a 1 hour kind of clinical correlation talk I would do. So we wanted to say, don't let perfection be the enemy of good in starting, and that there's no wrong way. Any way you can get them a little bit of knowledge, whether it's that acquisition, interpretation, or clinical integration. Anything is better than nothing. And more recently, maybe I'll shoot you this email or I'll email you this paper out of University of Utah. I just saw it not that long ago, a publication about internal medicine clerkship. I think it was an asynchronous experience. So even if the students didn't have a teacher in the internal medicine clerkship, they were able to do it.
Thank you. So, Renee, I'm pretty sure you have come across this from the patient's perspective. How do they take it when we do the ultrasound? You have mentioned a few times that we will do comprehensive ultrasound by the sonographers or by the radiologists. As we are not the radiologists or sonographers, when we do the point of care ultrasound, how do the patient take this?
For the most part, patients love it because anything we can do at their bedside and any time we spend at the bedside in the clinic or in the hospital provides that sense of value. I don't remember who published it, but the study that if you sit at the bedside while you're rounding on your patients, they think you spend longer in the room than you do. I'm not saying I'm trying to trick my patients with POCUS, but you really are spending that extra little bit of time in there. And oftentimes I'm talking to them while I'm doing it. So I'm learning about their dog's name and where they went to high school. So it provides this additional relationship building. And people generally love seeing their insides. And then they also, some patients will say, I don't care, I don't want to see it. Sometimes the family member wants to learn about what's going on and you get to teach them. And other times ultrasound can be an incredibly powerful motivational tool. So I was shadowing a primary care doc back in Florida. And so I was going through her clinic with her all day long and we were just ultrasounding. So her patient was on one of the PCSK9 inhibitors. So Repatha was the brand name. So she says, Doc, I don't want to take my Repatha anymore. I have to get an injection. My copay is expensive. I just don't want to do it. And my cholesterol numbers are fine. So we were able to ultrasound her carotid and we showed her these plaques. And we said, even if the numbers circulating in your bloodstream right now are not high, this plaque is long-standing damage that has to be treated. And she was like, oh, totally get it. My mom had a stroke. I'll take it. So I love that for our heart failure, our, prostate, our patient with LUTS, you could show them like the really big prostate and like, this is why you're on that med, for instance. And the patient educational perspective is yet to truly be tapped or published. I think that's something that I would love to have more data about. In the emergency medicine literature, patients felt that their doctors were more competent if they used ultrasound, and patients did not have any discomfort with ultrasound. But I would love more data in this area.
Yeah, I think there is a lot of work needs to be done, but personal experience is that the patients love it, the relatives or the family members, they love it. And it improves the communication in such an extent, it's unbelievable.
Yeah, totally agree.
With regards to the collaboration, Renee, what is your take? There are different specialties, internal medicine, emergency medicine, ICU, anesthetic. We are all using point of care ultrasound in different ways. What are the scopes of collaboration in this field?
So I started off with collaboration out of necessity. And then I learned the more people you know and the more people you work with, the better you'll be and the more you'll get done. So in the beginning, I was trying to learn. And in 2014, the World Congress for Ultrasound and Medical Education was at OHSU. So we hosted it. And there were like 5 other internal medicine docs. I didn't have any presentations, but I was starting to build a curriculum and stuff. And so there were like 5 other internal medicine doctors that I didn't even know existed in the world. And so then we got to network and we got to talk about what they were doing, what I was doing. Before that, all I could do was follow around the emergency medicine folks and just try to extrapolate everything I could. Or cardiology. Dr. Bruce Kimura was wonderful and let me and my other coworkers shadow him in his workspace for 2 days, which was very foundational for me early on. So that was necessity in the beginning. And I would go to these ER conferences or other conferences and be like, hey, I'm here too. I'm learning this too. And then it became that they were like, oh, hey, Renee's one of the internists. And when they would get hit up by their internal medicine team, they could ask me questions or I could help out, or I could say, you know what, this person's closer to you and wonderful, you should talk to them. And then over time, publications, obviously, it's easier if you get different, especially when you're trying to do something new. Just talking about what you do at one site is less exciting than saying what, like that clerkship paper, this is what's going on at 7 schools. And then in terms of moving the needle at your clinical setting, collaboration is truly key because your leadership may have the sense that like everyone's running around with handheld devices like packs of rabid wolves running around the hospital doing whatever they want, and they tend to think it's too new, there's not enough data, and there's no standardization or process. And they're wrong. And so if you're able to bring together at OHSU, now it started as a educational consortium of sorts. We called it the POCUS work group or something. But for, I don't know, probably like 7 years now, it's been the group to talk about what should the standard workflow be? What should privileging and credentialing look like at our site? What should the hospital pay for or not pay for? Because, for instance, in the beginning, it might be, well, hospital medicine has to pay for machines on those hospital floors. But you know who else sees patients on those hospital floors? Cardiology, pulmonology, hepatology, ICU, in and out. And so we were able over time to get together and say, we all see patients and we all deserve, and our patients deserve, ultrasound machines on these floors. And we need a middleware to make it better and for accountability. So they saw that we were working towards processes, and then we would be able to like pitch the pro board or pitch hospital administration on this software will help us connect to the electronic medical record so that everyone can see what I saw and what I thought. So that's kind of the full spectrum of collaboration, and never buy anything or do anything without asking people at your own shop, because maybe they realize that that particular machine, the touchscreen gums up after a while, or they already spent $10,000 on a software, but maybe adding another license to it is only $2,000. So there's a piece that I had written with Noel Northcutt and Rob Ferry, and it's called Building and Maintaining an Ultrasound Program. It Takes a Village. And the entire thing of that is collaboration. So I can send that one to you too.
Excellent. Thank you for sharing that. I think collaboration is such an important thing, especially in this evolving field of point-of-care ultrasound. And most of the emergency colleges, they have actually mandated it for their trainees, but also the ICU, as you have said, anesthetist, gynae obstetrics, pretty much everybody use it. Even the general practitioners, or what you call it, the primary care physicians, they are using this. So collaboration is a very useful tool because we can learn from each other, which is fantastic.
For sure. Absolutely.
So what are the future directions you envision for the development of point-of-care ultrasound, especially in its training and its application, Renee?
Yeah, so I've made this prediction before, and it's not just because I am a chief medical officer of an ultrasound company. In addition to being at a university, I have 2 hats. But here's the thing. Our students that are learning anatomy, physiology, the physical exam, clinical reasoning, and everything with ultrasound, they're not going to be able to function without it. It would be like telling people now, no, you don't get x-rays, you don't get CT scans. So for these schools that have fully integrated across 4 years, those students will never be without devices. They'll never take contracts without devices. It'll never happen. And over time, this is going to become so foundational. I do not call it the next stethoscope. I know a lot of people do, but to me, they're different because there's a million reasons why. It's a whole box of worms, but it's going to become a foundational piece of equipment that I believe everyone will have. And I like to say also, I hope it's going to go down and out, not in a bad way, but like down the educational spectrum from fellowship trained to residents, to med students, to nurses, to paramedics, to CNAs, to everyone. So down and then out, pre-hospital, post-hospital, skilled nursing facilities. We have so much waste in our healthcare system that I hope we can leverage this in transparency and communication to help some of those like the rotating door of patients in and out of the hospital. I think we could keep a ton of patients out of the hospital.
Mhm.
And you were earlier, we talked about training, and I forgot to mention the fellowship. So at OHSU, we developed the second general medicine ultrasound fellowship in the country. Now we have 3 a year, and we do family medicine and internal medicine. I don't think that fellowships will go away, because eventually everybody will learn this, but you still have to know how to run a program, how to QA, what you want from software, how you want to teach. So I think that fellowships will still be of value for people that want to become true leaders, especially in academics.
Mhm.
But I think everything else is going to become so ingrained in medicine, it's not even thought of as like a different thing.
Thank you for sharing that. Now, obviously, Renee, you have been using this point of care ultrasound. You have been involved actively in the process of training of the medical students and the clerks, even the senior doctors. So what will be your main advice to those clinicians who are using the point of care ultrasound or are interested in using it in their future career? What will be the tips and tricks?
Yes. For sure. Reps, reps, reps. You got to practice and never let a good crisis go unused, or that sounds strange. Never let a good diagnosis go without ultrasound, especially when you get these patients who have a pneumonia. They already have an echo, they have a CT, they have gallstones. Always scan those patients. We have so much pathology that we take care of every day. If you just took 5 extra minutes to scan everything you know is there, you would be building your image acquisition skills in addition to your interpretation skills. So try to scan everything you can. Don't let perfect be the enemy of good enough. And if you can make, I guess the thing would be, don't let perfect be the enemy of good enough, but don't make a call on garbage. So we have to make sure, again, we're taking all of the clinical data. Ultrasound is just one piece of it. And I may only have one real-time ultrasound image during CPR, but if that shows me a pericardial effusion and the patient's already dead, we're doing CPR, get your cardiologist or ICU doc or someone to do a pericardiocentesis. It's not like you have to have for your perfect comprehensive ultrasound study in that setting. So I think knowing what's diagnostically sufficient versus what's enough to just get the job done. So ugly images are often useful images, I guess is how I would say that. And just, yeah, keep practicing. And the last thing is I really love just-in-time training resources. So I'm going to mess it up because I'm not going to say all of them, but the POCUS Atlas is really phenomenal. It's kind of like Google of ultrasound images. POCUS 101 has a lot of, if you're like, I need to refresh my memory on how to do this study. Core Ultrasound has the 5-minute sonos. So just in time stuff, if you've never done it, or maybe you haven't done it in a year, refresh your memory before you go do it. So get a list of your favorite resources and just pound on those too. Sorry, that was a lot of tips and tricks.
Excellent. Thanks for sharing. That was very powerful advice, actually. And of course, I'll not forget your those tips for the training of the seniors. I think it is applicable for everybody, even the juniors. So use a hook, and then we can use the callback techniques. We can teach the why, and of course, leverage the old knowledge, and lots of hands-on practice, and don't stop learning. That's such a
Exactly.
powerful advice. Thank you for sharing that. And we got a lot of you've got quite a few articles there. I'm sure my colleagues and the viewers will look at them.
Yeah,
Thank
and
you
I'll
very
send you
much
that other one too.
Thank you for taking your time, and it was excellent. Thank you for sharing all your wealth of knowledge and expertise. As always, it was fantastic, and we look forward to seeing you again.
Thank you so much. It's been my pleasure.